Hello and welcome to the Integration Gap, the final webinar in the two-day InsightHive webinar series. I think we've saved the best to last. I've got two great guests on the panel today. As I said, the title is The Integration Gap, the reality of creating a unified patient view across fragmented digital environments. Before I introduce my panel, there's just some housekeeping we have to do. So yeah, there we go. So webinar housekeeping. All participants, obviously apart from the panel, audio and video is disabled, so please don't try and enable them. Please post questions using the Q&A function at any time. Depending on how many questions we get, we will try and get through those, save a bit of time at the end. The session is being recorded. You'll get a recording within 48 hours. I've been reliably informed that all the InsightHive webinar videos will be available on the HIC YouTube channel, so please check that out. And if you've registered for this, you'll get these slides via email as well. Okay, so excuse me, just a little bit about what Healthcare Innovation Consortium does. Obviously, we run the electronic patient record network, and that's really about making EPRs work in practice. So we do a lot of discovery work, defining what the problems are, helping with the implementation, getting that implementation of the EPR right, and then after optimizing the EPR after go live, making sure that it's delivering the benefits that it's set out to do. We're trusted by 70+ organizations. There's a few badges at the bottom of the slide there of some of the organizations we work with. Next slide, please. Yes, so a little bit more about the EPR community network. It's a safe space for healthcare leaders, vendors, suppliers to collaborate and share learnings. We host regional and national healthcare events, and we just give everyone a voice and bring people together. The next events we've got coming up in partnership with Conventus Group are the EPR Scotland event in September, in Ireland, Dublin, Ireland on the 15th of October, and in Cardiff, Wales on the 18th of November. And now it gives me great pleasure. Obviously, I'm Andy Miner. I'm the CTO of HIC. And with me today, if you can both introduce yourselves. First of all, Roddy, please just tell us a little bit about yourself.
Thanks, Andy. Thank you for having me. And hello, everyone. So my job is product owner at Harris Health Alliance, where I look after the Connect platform that supports interoperability and integration across, throughout the NHS. Prior to that, most of my work, or all of my work experience, was in primary care sector, and in the last year since joining Harris Health Alliance, I'm quickly learning about secondary care and all the sort of issues that we're about to talk about shortly. Over to you, Anne-Marie.
Thank you. I'm Anne-Marie Cunningham. I'm a GP in Northern Ireland, in County Down in the Mournes, and I've only been there the last 3 years because before that I worked for more than 20 years in Wales. And I have a few other roles alongside that. Just at the start of this month, I started as the RCGP's clinical lead for data and digital. So I'm doing that part-time, and I'm also still working with the Department of Health in Northern Ireland as a GP medical advisor. And my background in the last 10 years or so has been in digital roles and clinical management alongside being a GP. So.
Brilliant. Thank you both for coming on the show. Right, so let's get the ball rolling. There's a lot of talk at the moment about single patient record. So we thought we'd frame this by looking at what we're calling the integration gap. So it's not just a technical gap between the systems. It includes technical connectivity, semantic interoperability, one of my favorite buzzwords, data quality, workflow integration, often overlooked, operational handoffs, clinical usefulness, and just general trust in what people are seeing. So one of the main misconceptions, I think, in the general public is that they think the NHS as a single organisation, and therefore the data should be available throughout. We know the reality is far from that, and in reality it's fragmented, all over the place. So I'm going to start with you, Anne-Marie, with the first question. From a clinical perspective, what does fragmentation look like in real life across hospital, primary care, community mental health, social care, etc.?
You know, I'm just visiting here with my parents-in-law in Devon at the moment, and I said to them, I'm on a webinar this afternoon, and they said, what's it about? We probably won't understand. And I said, it's called the integration gap. And they said, I think we understand. And I said, well, what would it mean to you? And they said, well, for GP practice, if my father-in-law goes to ED, the GP practice doesn't straight away know what's going on. And I think that the biggest gap for all of this, we said from the clinical perspective, the biggest gap is really for the patients, isn't it? They're the ones who are the integrators across all of the systems and that we're continually relying on and who feel this burden most. It used to look like not getting information on time or it was coming in the wrong way. And increasingly, even whenever we think we've solved this problem, it maybe looks like having access to lots of information and the data's all there, but it might be buried and you maybe even feel overwhelmed when you do get access to all of this information to try and understand it and know who is leading, who's coordinating, what decisions are being made, when are they being made, what's the next steps that are happening. So for me, that's the next level kind of fragmentation problem.
Very interesting. And you're practicing in Northern Ireland now, Anne-Marie, and Ireland's now got Epic rolled out across the country. So with that in place, what has changed in day-to-day work and what has it not solved?
So it has solved that, and I think this is one of the things that we think about. We'd always talk about having things centered around the patient, but often they're centered around the service, aren't they? And that we're still sort of saying, so in Northern Ireland, now I can see everything. I can log in to the system and see the last trust in Northern Ireland went live with Epic just 1 year ago. So I can see for any patient, like if your district nurse had called out to see you this morning, I could log in and see exactly what the district nurse had done. I can see the referrals between one service and another. I can see all of the results. I can see a lot of things that are happening there. And one of the things, of course, is that we have relied traditionally in general practice of being notified. So people will say, well, I can't see it, but should I be logging in to see this information? Do I want to be able to do this? And I think it behoves on us that when you have more information, it's this having the time to be professionally curious, to really want to pay attention to all the things that are going and spotting the gaps and seeing where things are, because I can now do that, but it takes time. And so do I move over into that kind of coordination role, which increasingly does happen with more complex patients, because I can see where one trust is referred to another, what the photographs look like, what they're thinking about, what their MDT notes are. I can see all of this information now, and with that, with great, it brings on a responsibility to nearly be trying to spot the gaps within it, because we know that this is where things go wrong, even when you have access to all the information. It wasn't in Northern Ireland, but just this week I'd been reading about the inquest of a young man who died, who was known to many services. And the family were known to many services, but there was not coordination across that. So this idea that you have somebody who manages to hold the whole family or the person, that it's not just fragmented in between systems and that people are passing over. Because if we believe that somehow or other just joining up records solves that, it doesn't. It doesn't. You still have to have somebody that's going, and it's not going to happen by magic. We will have to design our systems to have people who can have time to be able to hold the person together. Traditionally, that has been one of the core rules of general practice. So that is what we've done, and that's what integrated care records can really do for us if we have that. But it's working across into social care and into other systems as well, and being able to have those joined up kind of conversations and knowing when do you actually need to speak to, and actually having those mechanisms to have joint organisation conversations. So just having access to the information doesn't mean that all of that is solved.
That's a really interesting angle, and yeah, I guess with great power comes great responsibility. Is what I thought with my Spider-Man hat on. So moving on to the next question, then, Roddy. What do you think is the biggest misconception organisations have about achieving integration across care settings?
Yeah, it's it's a great question, Andy, and I'm hoping that people disagree with me to get a bit of conversation going. But from my experience, it's people always think it is just about connecting systems together, which Anne-Marie's really just touched on, because once you connect them together, there's all sorts of other issues spring up. And we've been talking recently to clinicians in Kent, and there's a great big debate going on, which kind of leans nicely into what Anne-Marie was saying about, well, who's responsible for the next part of the process? So I think a comment had been made saying, well, if I see a consultant's name, the what's regarded as best practices, I approach that consultant first. And there's all the perhaps old ways of doing things. And I think what Anne-Marie was talking about is you've then got new ways that possibly need to be imagined. And then the other thing also I've come across recently is that the people are talking, well, we're all talking on this webinar about primary care, secondary care, community care, mental health care, local authorities and all of that. And it's like, do we perhaps not need to, certainly in terms of primary care and secondary care, and I think just in terms of the NHS overall, not view it kind of more sort of holistically and in a less sort of siloed manner. But the key obstacles, and I'm being very selfish here from my experience, are around sort of governance and data sharing agreements, and they introduce, I mean, they're important, don't get me wrong, but what I've found at times is that they can really cause huge delays in the integration sort of process, which is frustrating. One other kind of recent sort of, I don't know, you just have these moments, don't you, when you're working on something, and a comment had been made that, again, going back to what I was saying, that we allow the way we work to be defined by the current structures, and so a lot of the funding is logically defined by acute, primary, community, mental health, etc., that I was just saying. And whereas integration should be seen more as a kind of horizontal sort of process, where you've got, again, going back to what I was saying about a more of a holistic view. But I think that goes back to Conway's law, doesn't it? That you ultimately get what the structure of the organization often has a major impact on your on the outcomes. So those are my thing. There's one final thought that I had concerning all this, was that the people that do the integration well often are the ones that have a leadership team that are kind of above these organizational boundaries that we've all been talking about, which can be quite unique at times. But if you've got that level of authority and the relationships in place regarding the integration process, I see that as something quite precious. And the technology simply follows from that. Is my thinking. So that's that. Those are my thoughts.
No, thanks, Roy. Yeah. And I think, just building on what you've both said, does a single platform or a single vendor in the case of Northern Ireland, does that solve the integration gap, or does it just move the problem to a different layer? Anne-Marie, what do you think to that?
So still we have the contractor primary care services are outside of Epic in Northern Ireland. And I guess one of the issues, there was work done, RCGP did, looking at workload in general practice and the hidden workload, and this kind of trying to track, say, like referrals, like has the referral been accepted, has it been rejected, what's gone on with it, it's bounced back, you have to do it in a different form, all these things. To some extent, by as Roddy was saying, because we have got, it's not that we've got single records across, it's that we've got single organisations. So Northern Ireland has trusts which have massive responsibilities. They do all of acute care, all of community care, all of mental health, and also responsibility for social care. They're still social care contracted privately, but the statute provision is all within the one organisation. So of course it makes sense. That's how we've managed to deliver a single record, because we've got a single organisation. But for us outside in general practice, working across that and those boundaries, you will still get some of that kind of coordination burden of being uncertain about when is it, who's doing that task. Am I meant to go in? Because we had a lot at the start where people said, oh, well, yes, your GP knows this now, or they can see this. And it's like, well, we have to go in separately and look, and it's not still triggering something in our workflow. And also, it's wonderful and it's amazing that patients have got so much faster access to their information, and they can see it all in their records. But they can maybe actually see it faster than their GP has looked at it, because the letter comes through instantly, and then we're going off and having to, okay, let's go in. Oh, yeah, we didn't actually. And yes, so you can see that letter, but it still doesn't have all the information that I actually needed. It doesn't tell me exactly what dose, or were they aware of this information? How do I be able to message them and actually have a conversation about the patient with them? We don't have inboxes in Epic. I can't digitally cut. So we're back to still, doing phone calls and trying to do that coordination. So I think a lot is solved by what I have, of being able to access it. But you know then what you don't know, or what you didn't know before, but there's still work in it.
Yeah, no, good point. And Roddy, so same to you, but focusing more on where do you think the operational disconnects are? So not just clinically, but administratively as well.
Yeah, it's an interesting question. So going back to what Anne-Marie was saying, it certainly does simplify things, but I think a lot of the devil is in the detail. And I was at the NHS Confed Expo last week in Manchester, and I sat, usual, you sit next to people and you start talking to them, and the lady in question was the Associate Director for Finance for Greater Manchester ICB, and it's kind of really, it's kind of obvious, but it's not the sort of person I normally talk to. But the reason for mentioning this was that she was just talking about the contractual complexity across all the different care settings. So I take it that applies to you in Northern Ireland, Anne-Marie, where, yeah, you've got a single record, but you've got all these different organizations with different policies, contracts in place that probably need simplification, and to achieve what, we'll try and remove some of the frustrations that you have. From a more technical point of view, one case I saw of a new system or a more modern cloud-based system being deployed was that you just exposed the technical debt elsewhere in the system. So it's a bit like, well, I'm going to build loads of new roads, but you increase the capacity, but through that increase in capacity, you simply find the next bottleneck, which I think is what we're talking about here as well, in terms of the medical equivalent. So those are my kind of initial thoughts, but it is underlying everything are, well, what is the infrastructure that all of this is sitting on, and what implications does that have? How quickly is that being financed? And Northern Ireland is an interesting case of underinvestment in their infrastructure. That is a personal opinion, but and I won't say what infrastructure, but I was slightly horrified by certain systems that they were still running on over there. So it's hopefully that answers at least part of your question, Andy.
Yeah, no, it does. Thanks, Roddy. So in England, we're going down this single patient record approach, which possibly will use existing infrastructure like shared care records, national record locator service, etc. But what do we actually mean? So this is going to provide a unified patient view. What do we actually mean by a unified patient view? So I'm going to go, Roddy. What's your definition of that? What would you say?
I'm going to hand it over to Anne-Marie. No, I'm joking. So yeah, it's a great question, and we've certainly been exploring it recently, and I don't have all the answers, so sorry, Andy. But I think the way we see it currently evolving is you're ultimately sort of aggregating different data sources, and those data sources cross over all the different care settings and stakeholders involved relevant to that patient. So I guess going back to your comments earlier, Anne-Marie, about like sort of multidisciplinary teams, that there is a big gap in terms of, well, as a clinician, I go in and I view that unified patient record, and I want to be able to see, well, who are all the people involved in looking after that patient. And going back to your, these sad cases where that there's a death as a result of of lack of knowledge across systems. That's certainly sort of one thing that it hopefully it will address. But as I say, it's just in my head at the moment, it's just all about aggregating the relevant information and I think in England, Andy, it's just about neighbourhood care. And I said to one clinician, so does that mean that you have a sort of all the underlying data, and then you put in who you are and what you do, and it just defines that screen? And he said, no, Roddy, no, it's just a standard set of information that any person looking after that patient needs. It's in other words, the basic information. It's not everything. It's just and I think going back to what you were saying, Anne-Marie, I will stop in a second, Andy. What we're talking about more and more often is how can we summarize all this information? And we're currently mapping this out on a particular project. It's not going to give us all the answers, but it's a kind of work in progress. So I hope that kind of is a partial answer, Andy.
Yeah, no, thank you. Yeah, very good. I always think, international patient summary is a good starting point, and I think it is the starting point. Anne-Marie, same question to you. Do you agree with Roddy, or what's your definition of a unified patient view?
So I think knowing, again, this part about Noah, I remember years ago, like when I worked in Wales, one of the area that I worked in Arnbevan University Health Board was one of the first that had its own the clinical patient portal set up. I was able to go in there and see lots of information about the patient, other test results, what was going on, all the letters, actually scanned in ED notes, one of the most useful things, knowing what had happened in ED. And I remember thinking before I had access to that, how would this be useful to me? Why would I look at it? I didn't even have a login. Why would I want to log in? And then I got a login, and then I was like looking all the time because there was so many different things that in a consultation with the patient would just come up, and I was like, oh, let me just check that. And I could go off and see. And the part that I didn't have access to at that time was the mental health record. And I remember meeting up with somebody in Welsh Government, and they said there was a new system coming in. And I said, well, I have access to that as a GP. And they said, well, I'm not quite sure. And I was like, well, then that's not going to really solve any problem for me, because that's great that you've got a new system. But unless I can know, particularly in something like mental health, who is the person that is the key worker for that person, when in the next being reviewed, what's actually going on, there is no use. And I think it is those services alongside where you're, being able to see the most riskiest things often, what is actually happening. Yeah, it's great whenever you can see you don't have a UNE, but you can see the most recent one in the hospital. Great, yeah, but it wouldn't be the end of the world if you had to go and do that test yourself or whatever. Great to save something. But when you can actually have access to in-depth information that you might not have known otherwise, whenever you're particularly worried, that really is useful. So for me, I have never had the altogether things being summarized down. For me as a GP, would I go off and look at just a summary? Would I go off and look just to see what somebody else had recorded as the medications or the things? Am I curious really about that? Well, to a certain extent, but I'm going to probably trust more what I'm actually have got in my own system, which as a GP will always trust as being the single kind of the point of source of truth and whatever, and what the patient tells me, because I spend a lot of time talking to patients, so what they tell me is the important thing, and I'm usually going off to another place to check or to verify or to be curious about something in a very particular sort of circumstance. So we could tie ourselves in knots trying to think, how could I make a view for a GP? How could I make the view for the ophthalmic surgeon? How could I make the view for the optometrist in the community? Could we create all of this in a different way? Somebody has said, could AI be useful in actually doing this? Yeah, it might be, but also good search is just. So, just being able to search a record and see when was the last time the knee was mentioned, and where are all the things about knees, because that's what I'm interested in today, is maybe okay. Because if I'm going to have AI doing it, I will want everything to be clickable back, because I am not going to trust the provenance. I'm going to need to see the provenance of that before I would be really. So essentially I am using the AI in that sense as a search function. So search can do a lot for me in the moment.
Yeah. So is that the most thing that's most important to you from a clinical perspective then? So identifying the risks, verifying the patient record. Is there anything else, from a clinical perspective?
So knowing things like that I want the patient to have information to, like really that all of this about where they are in the referral list, what's happening, when's their appointment coming up, all of those kind of system things, which for most people that are not, again, those are not really critical, but they create a lot of work because people have uncertainty about what's actually going on. So you've got the things which are like, busy work that happen because you're not able to just know the answer. And then you've got the times whenever you're seeing somebody and you're worried about them and you're trying to figure out, you're thinking, this person, there's something not right here, and I need to read as much as I can and understand as much as I can to be able to make the right decision with them about what is the next thing to do, which is different to that low level admin kind of work where you just want the system to work better, and we're all frustrated why we just want it to work better, versus the criticality.
Yeah, no, very good point. Moving slightly on then to Roddy, kind of more from a kind of integration supplier perspective. What do you think has got to be in place for a unified patient view to be meaningful rather than just another screen?
To be meaningful, I think it's going to require a lot of work across the supplier network, shall we call it, to perhaps define a model of sharing data better. I think the current structures, well, some of them are fine, but they do also present barriers. And I do wonder, sadly, I don't have all the answers, but I'm kind of intrigued as to how you perhaps bring suppliers together Often everyone is naturally very competitive, and that could immediately cause issues if you're trying to collaborate. So I'd be quite interested in seeking a more collaborative model amongst organizations. Obviously, that this particular group is a good example of people sharing scenarios across, trying to just solve problems for our customers ultimately. Possibly we want to drive innovation more quickly. Certainly, I've been involved in healthcare, not the same length of time as either you, Andy, or you, Anne-Marie, but come from a finance or banking background. But I've always been slightly shocked at the lack of urgency. and there could be many reasons for that. I'm not going to blame people, but that's certainly something that frustrates me at times. So it's just trying to sit down and share. I don't know if you need like some form of ACAS for healthcare. You get all these people in a room and you get them to thrash out what they can all do together. So those are my thoughts for what they're worth.
Thanks, Roddy. And I'm obviously involved in open standards, and I fly in the open standards flag, but that only gets you so far, and you do need to kind of you need to have that will to cooperate as well. One of the things that really kind of struck me about the shared care record program is the variation across there, and I think it's fair to say that the majority of those shared care records, they bring the data together for a human to read, a clinician, yeah. But we're in the AI age now, yeah. So we need to bring this data together, and I think there's a question in the Q&A about AI, and you mentioned it, Anne-Marie. So if we're gonna bring this data together for AI, as they become more common, what should we insist on before they're trusted in clinical or operational workflows? And maybe what's the difference between those clinical and operational workflows? And maybe talk a little about that, Anne-Marie. Yeah.
I suppose if I start by saying, so what are the things that we're actually having AI happening and using sort of now? Like I just saw yesterday, skin analytics product Derm has been approved as a class 3 device to be used with taking a photograph on your own phone. It can rule out whether or not you've got a skin cancer, and they took 10 years to get to that stage or longer. That's a wonderful product. They've done all of the work, and they've got everything now that people now that it's probably better to have the cancer ruled out by that application than it is by a dermatologist. A dermatologist will be more risk averse and will probably biopsy you and do you maybe possibly some harm versus the AI. So why does that work? Because it's large volume, it's tightly bounded, and that was done on traditional kind of machine learning, but now you're starting to have coming in the generative approaches. There's a Korean product which is doing reading chest x-rays with a generative AI within that. Not as perfect as maybe that you still have to have the clinician then coming and reviewing it, but that's kind of acceleration. But all of those things, often image based or with very fixed kind of values, clearly kind of labeled outcomes, that's the role where AI is very, very clearly has a role. Now, my kind of work, which is much less boundaried, and as we're sort of talking there, but what is it that when do things go wrong? Because you haven't got the whole view of all the information. The synthesis, the trying to pull things together and make meaning out of it, that's where the gaps are. And so you're trying to pull it and work with somebody else and say, well, what is the thing that's most important to you? How do we actually make this decision together? is that something that AI can sort of do? Well, I've got my Claude Max subscription. I love it, but I still come across lots of mistakes, which make me believe that it's not quite there yet. We've got a lot of work before we have got all of that solved, where I could be really confident and trusting that, okay, here's a summary generated from the record, and you can trust that without going and looking at these other sort of bits, that I would have that confidence. It would take me a little while, but it maybe will happen quite soon. Once that is there and comes along, but it's not the space. We don't have any products around that are like that. If somebody has the products and knows about it and can demo them. I've got a friend who's like mocking one up on a synthetic data set. So that's the kind of space that we're in at the moment, of people kind of trying these things out, and yes, it could be good, and it could be there. With regards to the other bits about being able to predict, one of the things in that inquest that was sort of mentioned was, you cannot tell, trying to say do suicide risk. There are no tools that kind of predict this. Most of the people who sadly end their lives by suicide are low risk in the kind of scoring. So there's no metric that actually sort of works that. But you probably can look and say in an area or in a population, how many, just looking at it, it's kind of predictable how many suicides sadly will happen, more or less. But you cannot tell which individuals. Just the same way that we can know we can know how many people are going to turn up on an AD on a Tuesday or a Monday after bank holiday or whatever, and depending on the weather, you can model all those things. We've been able to do it for years, but we cannot say which individual will turn up. And I think that that's the bit, if we get to some place where that actually changes and we can do that kind of individual level prediction, but more it is not about, these things are so complex, and it's about criticality. It's like a kind of a power law happening about why for any one individual they end up having a certain event happen to them, that it's hard to still hard for me to believe that we can predict all of those things.
Yeah.
And instead, the best way is probably to focus on doing the good stuff well, and that general kind of approach, and moving the whole population, and managing people that way, rather than thinking that we're going to get enough data to suddenly know you're an individual that this thing's going to happen to. I can tell you more about studies which have shown that doesn't work, but I'll leave it at that.
Okay. Yeah. So it sounds to me like you're a fan of AI, but you don't quite trust it enough to do that. And I think trust. One of my favourite sound bites is digital transformation in health moves at the speed of trust. I can't remember who I heard it from, but I love it. I love it. And one of the common objections around a single patient record is that there are some, in society who just don't trust the government when it comes to, they're going to have all this, patient information, patient data, and they might sell it to insurance companies or whatever. So trust and data ownership are really key and major concerns here. So Roddy, question for you.
Yeah.
When we ask who owns patient data, are we asking the right question? Should we talk instead about data controllership, stewardship, accountability, and patient public involvement?
Yeah, I quite like, the sort of controllability and trustability. I mean, politically, on one hand, and Anne-Marie might object, but I've often, in simplistic terms, it's like, well, hang on a minute, I'm the patient, therefore I own the data. But I think it's more nuanced. It's not life's never as simple as that. But I am kind of interested, just kind of touching on what we were saying earlier, actually, about sort of data sharing and how we manage that better moving forwards. So it's those are my initial thoughts. Perhaps you might prompt some more, Andy, with another question.
Well, I'm just going to fire the same question at Anne-Marie. Yeah, just to get your thoughts on data ownership. Who owns the data? You're a GP. Do you own the data, or are you a steward?
I don't know why Roddy would think that I would object to some notion of the patient owning the data. The thing is that ownership of data doesn't have any meaning under GDPR. So it's like, what does it actually mean to say you own the data? Does it mean that you have a right to have access to it? Patients should have access to all the information that they want and that they want to be able to manage, and that they can go off and do other things with it. I have no objection to that, and I don't think that many GPs do. The patients should be able to, and citizens should be able to have access to that and link it up and do other things with it. And if they want to put it through ChatGPT and come up with something or other, go for it, do that. That doesn't absolve the responsibility of me or the citizen or anybody of the system for actually making sure that we use the data well and that we use the records well. And it would not, and I would fear that if you sort of come up with something which has a very individual framing, like, oh, actually, citizen, it's your responsibility to make sure that data is shared between those people and whatever. Well, that's not fair, because the people that most need the use of the health service and the social care service are really, they're unwell, or they're older, or they're frail, or there's other family members and things involved in it. So and they should be able to, we should solve problems of proxy access much better than we do now, so that people that are carers and family members should be able to get access to that data as well. So I think at the individual level, it's about just kind of framing as being like an individual problem is not the right sort of approach to it. With regards to should you have I think that we could. So to me, it's, even if we come down to the controllership bit, with the single patient record, we're hearing things that it's going to be mandatory to share within it. Clearly, then that is, you're not going to, as a GP, I wouldn't be controller of that information if I've been forced sort of to share it, because it's mandatory. So, but I still think that there would be a role for professionals and for patients in some way to be stewards of that data and to make decisions around how that data is used. There is a lot of vagueness in the new bill and the mention of the single patient record. There's a lot of and maybe that makes it easier to work with and to get through Parliament and things like that. But some of the things that you would hope would be safeguards in there are just not as transparent or obvious as you might have hoped. So I think that's going to be the work as it goes through committee stage of actually clarifying some aspects around that. But yes, does that answer your question?
Yeah, absolutely. Yes.
Okay.
And I can't read it. Richard has posted in the Q&A. It's a very long question, well thought out. I won't read out the whole question, but it touches on something that you both mentioned, that I've just got to find it in the what he says the question is. There we go. As services become increasingly interconnected, perhaps the more important question is not who owns the data, but how it can be stewarded responsibly, for the benefit of the whole system, and most importantly the patient. And I think that's a really an excellent point. But do you agree with that?
I think we need to, especially, when you come into commissioning like the voluntary and community sector, they have to do an awful lot of work to prove what comes out of their services that they're provided. And if we can some way have ways of actually knowing to be able to evaluate things better, to know if I set up a new service, I've got a hospital at home service, what's really the impact of that? Is this good? Am I getting good bang for my buck? I'm really interested in the idea of value and looking at outcomes and trying to see, what gives us on that system level the best bang for our buck. I absolutely think that system stewardship is something we should be doing better. But as we all know, at that micro level, you have that I could have access to all the patient's information. I still have to be able to make the work is still to make a decision on it. You can have access to a lot of information at a system level. The key thing is still being empowered and feeling that you can make a decision based on that. You can change your services around. You have got the levers to be able to do something with it, because we've had a lot of information for a long time that's maybe not been acted on in some ways as much as it could have been,
Yeah.
with regards to deprivation, etc.
Yeah, there's another comment in the Q&A. It's not a question, but I think it's. I think the people generally trust the NHS. I don't think they trust Peter Thiel. Amen, brother. I believe. Yeah, absolutely. I think we're all in agreement on that one. Question for you, Roddy. And from a more technical perspective, how can suppliers better support integration efforts without making all this about product claims? And what can suppliers do?
That's a little awkward, that last bit, because I would say a shameless plug would be, use the Connect toolbar. That is a method of connection. And that's the last bit of plugging I'll do. So, it just offers a marketplace where GPs can access the applications that they want, and it's coming through a single point of integration. So it's just simplifying the process of integration with EMIS TPP. Potentially one advanced if they come back into the English market with Vision or whatever they might call that product, and obviously the new entrants, or they're not really new, are they? Medicus. So yeah. That's me finished on that bit. I think certainly from my perspective, it would be about updating their underlying technology systems. So one example might be for TPP to move to a cloud platform rather than their antiquated install on a practice server. That would simplify many third-party product integrations into a GP system covering 40% of England. We've in past work, just modernizing your APIs, moving them from SOAP to REST or onto, other forms of API standards, just improving performance. So, you've got, so when a clinician, often when we have partner integrations, the clinician's tolerance of that system is directly proportional to how fast it works. And that, it's really sometimes, as I was saying earlier, it's the kind of the devil in the detail. And even one thing that's interested me recently was whether or not you could, how many integrated third-party systems through IM1 can a GP practice support? Because that is defined by how well coded all the products are. And I've had they will remain nameless, but integration partners, and the blame was being pushed onto, well, it's your system that's causing the problem, when the evidence ultimately was that the code the supplier had written was just slowing everything down. They rewrote it, and hey presto, it all worked well again. So it's those sort of things. Proprietary code, again, going back to your bread and butter, Andy, about adopting more standardized approaches to more modern databases, just all of those sort of things. So hopefully that answers your question, Andy.
Yeah. I would agree with all of that, and I would add to say that the vendors that get involved, because I've done quite a bit in the past integration projects, but that's the point. Only tended to do integration in projects when there's project time pressures, and everything else going around. And I think a great place to learn about integration and interoperability are interopen hackathons, IHE connectathons. Get involved. You work with other vendors, you meet other people, and get all this stuff kind of working before before the hospital says please connect them. That's just my view on that. So on a kind of similar-ish theme, where to both of you, I'll go with Anne-Marie first. Where can you think of any examples of good collaboration across care settings, or lessons from shared care records, from your experience in Northern Ireland, Wales, or anywhere else?
I was thinking, so one of the examples in Wales we have is the classic kind of example about medicines and putting together medicines, so that even in many places where you have access to all of it, you still don't have the people that are getting home care sort of solutions that the medicines are dispensed directly out to them. You don't know about that record. And Wales has been working on a shared medicines record, and they frame that and they say that is so that you can do the work of reconciliation. So there still is work to be done in reconciling back into your own home system, but you've got all of the views sort of pulled together. So that becomes and makes visible, it's not so much a single source of truth, but that plurality of truths of the different, the record in the different systems, and then a person can work and sort of make sense of that. Yes, there may be a time whenever the AI, something generative AI is helping us with that task and helping to do that work better, and that'll be great. That those tasks, which are the really burdensome things, are actually sort of going. But I think it was that comment earlier about the information, the Conway's law, the information, the organisation following the information, and your systems being that way. And I guess I have worked in settings between Wales and Northern Ireland where we are really very integrated. In Wales, we didn't have social care, but everything else was under one organisation. And Northern Ireland has social care but not primary care. So I think it's such a relief to work within in those sort of systems where you're not trying to figure out which the DGH down the road has got a different system. And I think to a certain extent, my feeling is that the shared care record implementations have done so much across England to be able to really start solving that problem. And that nail on the head is that it is a governance problem primarily. It is not the technical problem. It is the governance problem. I remember years ago speaking to Leeds Care Record, which was one of the forerunners, saying, how do you actually manage it? How do you decide who gets access to this record? How do you bring people on? What is the setup of the group that are actually making those decisions? How are you tracking it? What's your audit like? Those are the things which make or break these systems. I'm starting to get into the things like in Northern Ireland with being able to look at audit trails in there to say, well, who did see something? What did they actually look at? What was it actually put in whenever things go wrong? But most of the time it is that those bits about and I think that question that was asked by Richard about ambulance and others, how do you that's the place that we're into, is how do we do, and honestly solving it for the NHS is the easiest part. It is all the other stakeholders that are around. How do we do that, and do we manage that is that where we get into that space of the patient then saying, okay, I'm going to share my record with you. You're my podiatrist that I'm seeing privately. I want you to see it. You're the person that I'm speaking to. Do those other organisations really want to have access to that information? How do we share it back? How do we manage to have that same standards around governance that we spend? And we are very, comparatively well resourced within the NHS to be able to do. We can't expect a small voluntary group to be able to do it the same way. So how do we set up systems that actually support other organisations to do that kind of work?
Yeah, no, so my as well, our associate David Hancock, the chair of Interoperability, he says interoperability is a technical problem, it's a social problem. And I think you just highlighted it there with what you're talking about. Roddy, same question to you. Where are the good examples of good collaboration across care settings?
Yeah, sure. So a couple of weeks ago, visiting PCN in the south of England, and that was a great example of good collaborations across this particular PCN had 7 practices, but they are a national exemplar. But what was interesting was looking at well, how do you so they've had great success, they've achieved all sorts of amazing results, but what seemed a little, well, I asked some questions in terms of well, how well has this been adopted, and how can you scale this? But again, it comes back to, well, fundamentally, go back to what you were just saying about, it's a social thing. It's really about the capabilities, interests, and in Anne-Marie's case, her curiosity. You need curious people, and because not everyone is, but that's where I have great hope. And certainly I'm interested to look at the West Midlands. There seems to be some interesting work going on in that area at the moment, and just Greater Manchester overall as well. I'm not overly familiar with GraphNet and their shared care record, but again, like you were saying earlier, Andy, that they're all broadly, they've all got sort of differences, but doing the same thing. But kind of really interested to see how that plays out, and then break down, a bit like Anne-Marie was saying in earlier responses to questions. It's all about the differences between these organizations, and trying to find that common ground that provides good collaboration.
Yeah, no, thank you. Well, the time has absolutely flown by. I could honestly carry on talking for the rest of the session, but thank you both very much. Brilliant insights from you both. Thank you. And just before we talk about the slide, just one thing from one of you. What's one thing very quickly that a provider organization could do tomorrow to start improving interoperability? Roddy, you go first.
It's an interesting question. One of the things that came out at the NHS Confed, I went to some of the talks earlier in the morning, but the simple thing that came back to me, and the question that I think everyone should ask themselves is, how can we simplify the work we do? Because I think we've produced an awfully complicated system. So I'll stop there. Anne-Marie.
Yeah, that's brilliant. I love that. Anne-Marie.
I think that the word that we're going to keep hearing more and more about is relational, and it is to think how you can actually be relational, and that probably is not just supporting in relational care for individuals, but relationships between organizations. So how do you build that trust between the organizations and put effort into that, and not be blaming, it's not a blame culture. Not trying to, that, but how do we actually have those relationships supported across all levels? And it's not just about people. I don't want to make it sound like that comment I made earlier about being curious was like saying it's a failure of individual practitioners not to be curious. You have to have time, and that be respected to be able to do that. I think that we've got curious people, but we try and we focus too much just on churn rather than actually getting the most useful things out of it. So value your people's time.
Brilliant. Thank you both. Yeah, two extra insights as well. Right. Okay. Electronic Patient Record Network. We run specialist interest groups. These are really interesting because this is where we bring the NHS into small groups. We have special interest groups on maternity and neonatal, paper to digital. We're going to start in a pharmacy one. We're starting bed management, patient flow one. So we're going to be doing more of these special interest groups. We bring the NHS stakeholders in. They talk about their problems, they collaborate, they share ideas, and then we bring our network members in who are software vendors to help them solve the problems. It's a great way of engaging. So if you'd like to get involved and join a specialist interest group, the QR code is on there. Please scan and come and get involved. Next slide, please. Yes, regional EPR summits. I mentioned them at the beginning of the hour. We are doing 3 more this year. 1 in Scotland, 1 in Ireland, even though the map's showing it in Northern Ireland. I believe it is going to be the Republic of Ireland, and the final one in Wales in November. If you would like to join the waiting list to attend these, then please scan the QR code and it'd be great to see you. And of course, please connect with us. Emails are on there. So please connect via email, drop me a line, drop Roddy a line, connect on LinkedIn. Let's carry on the conversation outside of this. Thank you very much. That's a wrap. Thank you to our panel. Thank you everyone for attending. That's the end of InsightHive. Thank you. Bye-bye.
Thank you.